Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Have you ever stopped to think about what's lurking right under your sink? Or maybe even in your medicine cabinet? What if the very cleaning supplies we use, or even some everyday medications, actually held this hidden power to chemically destroy living tissue? Today, we're going to plunge into a topic that's, well, it's surprisingly common, yet potentially really, really dangerous.
That's exactly right. We're exploring caustic ingestions. Basically, these are cases where someone swallows a substance that chemically burns and destroys the body's tissues right on contact. We're talking particularly about the lining of the digestive tract. And these agents, they're ubiquitous. You find them in countless homes, industrial settings. It leads to, tens of thousands of exposures every single year just in the U.S.
So our mission in this deep dive is to really get our heads around this complex medical challenge. We'll look at the different ways these chemicals cause harm, where they're hiding, sometimes in unexpected places, how the body reacts to such an assault, and maybe most importantly, the critical steps involved in diagnosing and managing these injuries. Think of it like a shortcut to truly understanding a critical medical emergency and maybe uncovering some surprising facts along the way.
And it's so important to understand that managing these injuries is anything but simple. It's not straightforward at all. It really demands a comprehensive, multidisciplinary approach. You have to consider the diverse origins, the specific chemical properties, and these progressive phases of tissue damage and eventually healing.
Okay, so let's unpack this a bit. When we say caustic, what exactly is that? And how do these substances wreak such havoc on the body?
Yeah, good question. At its core, a caustic, or you might hear corrosive, is really any substance that chemically destroys tissue when it directly touches mucosal surfaces, like the lining of your throat or stomach. But there's a really key distinction in how they do their damage, mainly between acids and alkalis. And it has, well, significant implications. So first, you've got acids. These are proton donors, chemically speaking. Injury gets pretty severe typically when the pH drops below 3. Their characteristic injury pattern is something called coagulation necrosis. You can sort of picture the tissue drying out, becoming denatured, and forming this thick crust. Doctors call it an eschar or coagulum. The theory, at least, is that this eschar might sometimes act like a barrier, limiting how deep the acid can actually burn.
Oh, like a protective scab almost.
Yeah. Kind of, yeah. And another thing about acids, they often have a really strong smell and cause immediate, quite sharp pain, which thankfully can sometimes limit how much someone actually swallows. The pain response kicks in fast. Common examples, hydrochloric acid in toilet bowl cleaners, sulfuric acid in, say, pool cleaners or car batteries. Oh, and they can sometimes cause these skip lesions, so patches of damage that aren't all connected.
Okay, so that's acids. What about the other side, alkali?
All right, alkalis. These are proton acceptors, and they cause severe damage when the pH is high, usually above 11. Now, their injury mechanism is very different. Liquefaction necrosis. Instead of forming a crust, it's more like the tissue starts to dissolve or liquefy. This involves processes like saponification of fats, disruption of proteins, and the key point is this process allows the alkali to penetrate much deeper into the tissue. It can potentially burn right through the entire wall of the esophagus or stomach, leading to perforation. That's a hole. And here's the really insidious part. Alkalis are often colorless and odorless, and they might not cause that immediate sharp pain. So someone might ingest a much larger quantity before realizing something is terribly wrong, leading to far more extensive burns. The esophagus is particularly vulnerable because liquid can kind of pool there, prolonging the contact time. Think lye sodium or potassium hydroxide found in drain cleaners or ammonia in some cleaning products.
So acids create a kind of protective crust, while alkalis just keep on digging deeper, melting the tissue away. That sounds like a huge difference.
It is a fundamental difference in mechanism, absolutely. How they interact with the tissue initially is quite distinct. However, and this is really vital to stress, despite those mechanistic differences, in practice, both strong acids and strong alkalis are equally capable of causing incredibly severe full-thickness injury. The end result, unfortunately, can be just as devastating regardless of whether it was an acid or an alkali. Don't underestimate either.
Right, okay. That's a crucial clarification.
Mm-hmm.
Are there other types of caustics then beyond these two main categories that we need to think about?
Yes, absolutely. The definition isn't strictly limited to just strong acids and bases. Other agents can cause very similar damage. For instance, you have things like phenol and formaldehyde. We sometimes call these protoplasmic poisons, basically. They mess with the fundamental workings of cells. They cause severe internal injury, but also often significant systemic symptoms throughout the body. We also see caustic-type damage from substances like iodine or highly concentrated hydrogen peroxide, specifically solutions over about 30%. Even some older medical items like Cleanatest tablets for urine sugar testing or things like creosote. And a really important one to highlight these days, the ingredients in laundry detergent pods, those little LDPs, and also some electric dishwasher detergents. These are super concentrated, and because they're often gooey or gel-like, they stick around longer, increasing contact time and leading to severe burns. They've also been linked to higher toxicity, sometimes causing issues like CNS depression or breathing problems. And certain types of detergents, cationic ones, can cause nasty burns if they're concentrated enough, say above 7.5%. Also worth a specific mention. Zinc chloride and mercuric chloride. These are tricky. Their pH might look relatively normal, close to physiologic pH, so you wouldn't immediately think caustic.
Yeah.
But they possess what's called a high titratable acid alkaline reserve, or TAR. Think of it like hidden energy reserve. They have a huge capacity to keep reacting and causing progressive damage long after initial contact. Plus, you have the added risk of systemic toxicity from the heavy metals themselves. And then there's a broader category including oxidizing agents, desiccants, vesicants, even things like hydrofluoric acid, which causes its own unique severe problems.
Okay, here's where it gets really interesting for me, and probably for a lot of listeners. Where are these dangerous substances hiding in plain sight? And what makes some exposures worse than others?
Yeah, this is absolutely crucial for awareness because these things are just everywhere. We can broadly categorize them into household and industrial sources. Household products, these are unfortunately the most common culprits in accidental ingestions, especially involving kids, top of the list. Drain cleaners, extremely hazardous, often contain really high concentrations of alkali like lye-sodium or potassium hydroxide, sometimes up to 30% or even higher in crystal forms. Or they might contain strong acids like sulfuric acid, up to 93% in some liquid products.
93%, wow.
Exactly. Then you have general cleaning products, regular household bleach, the dilute stuff, usually isn't a major issue, it's swallowed in small amounts. But industrial strength bleach, that can definitely cause serious esophageal necrosis. Household ammonia is usually mild, but concentrated ammonia, like 28%, has been reported to cause strictures, that narrowing we talked about, and again, those laundry detergent pods, LDPs, a really serious concern. It's the concentration plus the prolonged contact that makes them so much more dangerous than traditional powders or liquids. Other common household dangers: oven cleaners, often containing sodium hydroxide; toilet bowl cleaners, typically strong acids like hydrochloric or phosphoric acid; even rust removers can pack a punch with various acids or alkalis. Hair relaxer creams, while usually causing milder injuries if ingested, are another alkaline source.
Okay, but you mentioned something earlier, even pills. That's surprising.
Right. It's an unexpected source most people wouldn't think of as caustic, certain medication pills. While not corrosive in the classic sense, drugs like doxycycline, tetracycline, certain antimalarials, even aspirin, if they get stuck and dissolve against the esophageal lining for too long, they can cause significant inflammation and ulceration, pill esophagitis. And potassium chloride pills are particularly notorious. They can be incredibly damaging if they adhere, potentially even causing a full-blown esophageal perforation.
That's genuinely unsettling. What about industrial sources?
Industrial and specialized chemical products, these usually involve much higher concentrations. Exposures here are more often related to occupational settings or, sadly, intentional ingestions. Think agricultural or industrial cleaners, like those used for dairy pipelines that can contain strong alkalis. Swimming pool chemicals like muriatic acid, which is concentrated hydrochloric acid or sulfuric acid. And unfortunately, we see severe injuries from chemicals used in clandestine drug production, sulfuric acid, hydrochloric acid, lye, and so on. Under specialized caustics, we've mentioned phenol, formaldehyde, iodine, concentrated hydrogen peroxide, and again, zinc chloride and mercuric chloride are critical because of that high tar and systemic toxicity risk. Even button batteries. Newer ones often cause more damage through pressure or electrical current if they get lodged, but leakage of alkaline contents is still a possibility, causing a caustic burn. And then miscellaneous things, alkali powder in deployed airbags can cause eye burns, cement can cause nasty skin burns if contact is prolonged, even perfume can be caustic to the eye.
So it's not just what is swallowed, but other factors too.
Exactly. Several factors really influence how bad the injury will be. Concentration and pH are obviously key. Very low pH, below 3, or very high pH, above 11, generally means worse injury. But, as we discussed with zinc chloride, that titratable acid-alkaline reserve, TAR, is often a more accurate predictor of the real damage potential than just the pH number alone. Some things just have more bite than their pH suggests. The volume or quantity ingested is critical. Larger amounts usually lead to more severe, widespread damage. And the physical state matters a lot. Liquids tend to wash down quickly, potentially causing more extensive burns in the esophagus and stomach. Crystals or solids might stick in the mouth or throat, causing severe localized burns there. And those gel packs or pods, like LDPs, combine concentration with prolonged contact. Viscosity, how long the contact lasts, even whether there's food in the stomach, these all play a role too.
So what actually happens inside the body once these chemicals are ingested? It sounds like it's not just an immediate burn and that's it.
Yeah.
Right, there's more going on.
That's a crucial point, and yeah, it's often misunderstood. Caustic damage isn't just a single event. It unfolds in distinct phases of damage and then healing, and some of these phases carry significant delayed risks. The first phase is the initial necrosis and inflammation. This happens pretty much immediately within the first 24 hours. You get cell death, bacteria can invade the damaged tissue, blood vessels can clot off, all making the initial injury worse. Then comes phase 2, sliffing and low tensile strength. This is typically from day 2 out to about day 14, maybe even a bit longer. During this time, the top layers of the dead tissue start to peel away or slough off. But here's the really critical part. The healing tissue underneath has extremely low tensile strength for up to 3 weeks. It's very weak. This period, especially between day 5 and day 14, is when the wound is at its absolute weakest, and this dramatically increases the risk of delayed perforation. The organ wall could just give way, tear open, even days after the initial ingestion. It's a really dangerous time.
Wow, that sounds incredibly precarious, like the tissue is just barely holding together.
It really is. It's why close monitoring is so vital during this period, even if the patient seems stable at first. Okay, phase 3 is granulation tissue formation and re-epithelialization. This starts around week 1 and can go on for several months. This is where the body starts laying down collagen, new tissue forms, the surface starts to heal over with new cells. Basically, the rebuilding process begins. But this rebuilding process, the scarring, leads into the 4th phase, stricture formation. This can become noticeable anywhere from 2 to 8 weeks after the ingestion, but sometimes it takes months or even years. Esophageal strictures are essentially scars contracting and tightening, causing the esophagus to narrow. And the risk of getting a stricture is directly linked to how deep and how widespread the initial burn was. So grade I injuries, very superficial, almost no risk. Grade A, non-circumferential ulcers, rarely form strictures, but grade dive injuries, those deep ulcers that go nearly all the way around, have a stricture risk up to 75%. And grade 3 injuries, where the burn goes through the full thickness, the stricture risk is up to 90%, plus a higher risk of perforation early on.
That low tensile strength phase you mentioned, that sounds incredibly dangerous. It's like the body is literally holding its breath, and any slight thing could cause a disaster.
That's a good way to put it. It is indeed a very fragile period, and it's why careful management and sometimes limiting interventions during that specific window is so important.
This brings up a really important question then. If someone ingests one of these substances, what are the immediate signs? But maybe more importantly, what signs can't you trust? How much can we actually rely on what we see or, what the patient is telling us?
This is probably the single most critical and often the most surprising point for anyone dealing with this, especially clinicians. What you see on the outside or the initial symptoms often tell you almost nothing reliable about the severity of the internal damage. It's incredibly deceptive.
Really? Nothing.
Almost nothing predictive, yeah. Sure, you might see immediate signs. Severe pain in the lips, mouth, throat, painful swallowing, difficulty swallowing, drooling, maybe vomiting. If there's blood in the vomit, hematemesis, that's obviously serious, suggests erosion into a blood vessel. Abdominal pain, especially with fever or a fast heart rate, suggests severe injury too. But here's the kicker. Many patients can look completely fine initially. Normal vital signs, no abdominal tenderness. Yet they can have devastating burns inside their esophagus or stomach. I've personally seen cases where someone walks in, seems okay, maybe just a bit of throat discomfort, and then the EGD shows horrific, deep burns you just cannot judge by initial appearances.
Okay, wow. So external signs are useless?
Pretty much useless for predicting internal injury severity. Visible burns on the face, lips, or inside the mouth. They do not reliably predict if there's damage further down. The absence of oral burns doesn't mean the esophagus is okay, and vice versa. Same goes for abdominal pain or tenderness. Its presence or absence is a poor predictor of significant GI injury. No single symptom or even combination of symptoms can reliably rule out a serious esophageal injury.
But what about breathing? You mentioned that earlier.
Yes. That's the major exception where immediate signs are critical. Respiratory tract involvement is an emergent concern. This happens from direct inhalation or aspirating the substance. Signs like hoarseness, stridor, that high-pitched noisy breathing, or any kind of respiratory distress are huge red flags. Laryngeal edema, swelling in the voice box area, can happen incredibly fast and close off the airway. This needs immediate attention. Sadly, tracheal necrosis, damage to the windpipe, is one of the most frequent causes of death in these situations. Airway is paramount.
Okay, so airway signs are critical, but otherwise don't trust the initial picture.
Exactly. You also need to look for other things, burns on the eyes or skin if there was external contact. Signs of systemic toxicity from specific agents, like hydrofluoric acid causing dangerous low calcium levels, or phenol affecting the heart, and perforation, a hole in the esophagus leading to infection in the chest, mediastinitis, or in the stomach or bowel leading to infection in the abdomen, peritonitis. But again, the classic signs of peritonitis, like a rigid abdomen, are often late findings. The initial calm can be profoundly misleading.
Given just how unreliable those initial symptoms are, how do doctors actually figure out what's really going on inside? What's the actual extent of the damage?
Right, because you can't trust the surface picture. You need a systematic diagnostic approach. It really starts with the initial assessment, focusing on history and physical examination. The history is absolutely crucial. You need to know what exactly was ingested, what was its concentration, how much roughly was swallowed. Critically, when did it happen? And also the intent. Was it accidental, like a child grabbing a bottle, or was it intentional, like a suicide attempt? Intentional ingestions often involve larger volumes, higher concentrations, and sadly, usually result in much more severe injury. Did they ingest anything else, like alcohol? The physical exam focuses on the mouth, throat, airway, chest, and abdomen. But again, remembering the limitations we just discussed. The key things to look for are those airway compromise signs: hoarseness, stridor, drooling. Those are true emergencies, highly predictive of serious trouble. Systemic signs like shock, a very low blood pressure, or metabolic acidosis are also really ominous findings.
Okay, history and physical, keeping the unreliability in mind. What about lab tests?
Laboratory studies come next. Now, labs don't directly show you the extent of the local burn inside the esophagus or stomach, but they are absolutely critical for assessing the overall systemic impact, how the whole body is reacting. So initial labs usually include a complete blood count, CBC, coagulation studies like PT-PTT. Interestingly, elevated levels here have been correlated with severe injury. A comprehensive metabolic panel, CMP, to check electrolytes and organ function like kidneys and liver. And an arterial or venous blood gas, ABGVG, with lactate. Significant metabolic acidosis often points to major tissue injury or perhaps direct absorption of an acid. For specific toxins, you need specific tests. Hydrofluoric acid, you need immediate cardiac monitoring for heart rhythm changes, QTc prolongation, and you have to check calcium, potassium, and magnesium levels urgently because they can drop dangerously low. Overall, certain lab results like a very high white blood cell count, leukocytosis, high C-reactive protein, CRP, severe acidosis, kidney failure, abnormal liver tests, low platelets, these can be predictors of really bad outcomes like transmural necrosis, full thickness damage, and death.
What about imaging? X-rays, CT scans?
Good question. Imaging modalities play a role. Plain X-rays of the chest and abdomen are usually done first. They can sometimes detect signs of perforation, like free air under the diaphragm or air in the chest cavity, pneumomediastinum, but honestly, they have low sensitivity. A normal X-ray definitely doesn't rule out a perforation. Computed tomography, the CT scan, especially using intravenous contrast, is much more sensitive than plain X-rays for detecting a perforation. Hole in the bowel or esophagus, it's often considered the study of choice when you're seriously worried about a severe injury like that. They can spot that extraluminal air with high sensitivity, and it can see structures outside the gut that an endoscope can't reach. And this is a crucial point, CT should generally not replace endoscopy, EGD, as the primary tool for actually evaluating the injury to the lining of the upper GI tract. It's more of a useful adjunct, a helpful addition. It's definitely recommended if EGD isn't available for some reason, or if it's contraindicated, like if you already strongly suspect a perforation based on other signs. Some might do CT first in very severe cases.
Okay, so CT is good for finding holes, but not the main tool for looking at the burn itself. That sounds like the EGD you mentioned.
Exactly. Esophagogastroduodenoscopy, or EGD, is really considered the gold standard for evaluating the injury after a caustic ingestion. Its main utility is that it provides direct visualization. The doctor actually looks inside with a camera at the mucosal surface of the esophagus, stomach, and the first part of the small intestine. This allows for diagnosis, grading the severity of the burns, and, importantly, predicting the long-term risk of developing strictures.
You mentioned timing is critical for EGD.
Yes, the timing of EGD is super important. Ideally, it should be performed within 12 to 24 hours after the ingestion. Why that window? Well, if you do it too early, say less than 12 hours, the full extent of the injury might not have declared itself yet, so you could underestimate the damage. But if you wait too long, especially after 24-48 hours, and particularly into that dangerous 5 to 14-day window we discussed earlier, the tissue becomes soft and friable, really weak. Doing the EGD then becomes much more hazardous, significantly increasing the risk of the scope itself causing a perforation, an iatrogenic perforation. So that 12 to 24-hour window is generally the sweet spot.
And who needs an EGD?
Good question. The indications are fairly well defined. It's considered mandatory for essentially all intentional ingestions, regardless of whether the patient has symptoms or not. The risk is just too high to guess. It's also strongly considered, usually done in any patient who is symptomatic, things like significant burns seen in the back of the throat, stridor, chest pain, abdominal pain, or if they simply can't swallow liquids. Now, for children who ingest something accidentally and are completely asymptomatic, no symptoms at all, there's some debate. Some guidelines suggest you might be able to defer EGD and just observe closely. But many experts still recommend doing an EGD even in asymptomatic kids just to be absolutely sure, given the unreliability of symptoms. It's often institution dependent.
And when they do the EGD, how do they classify the damage?
They use a grading system. The most widely accepted is the Zargar classification. It grades the injury from grade 0, normal, up to grade 3, extensive necrosis, with subdivisions like II and IAB. Grade 0I are mild. Grade C involves superficial ulcers, often linear, non-circumferential. Grade I involves deeper ulcers, often circumferential or near circumferential. Grade 3 means extensive deep ulceration and necrosis, basically dead tissue, often appearing black or gray. And this grading is crucial because it directly correlates with prognosis, especially the risk of stricture formation and perforation. Remember, grade I burns, those deep and nearly circumferential ones, carry that high stricture risk up to 75%. And grade 3 burns have a very high risk of early perforation and later strictures, up to 90%. A key point during the procedure is that the endoscopist should usually stop advancing the scope at the level of the first severe circumferential burn they encounter to avoid pushing through weakened tissue further down. The main limitation of EGD, though, is that while it shows the surface damage well, it can't always accurately predict the full depth of the necrosis, especially for grade 3 injuries. And again, it's absolutely contraindicated if you already know or highly suspect there's a perforation.
Okay, so we got the diagnosis sorted. What does this all mean for someone who's actually ingested a caustic substance? What's the immediate medical response? And then what does that long road to recovery look like?
Right, the management. The absolute immediate priority, always, is initial emergency management and stabilization. Think ABCs. Airway, breathing, circulation. Airway assessment and protection is paramount, number 1. Any signs we talked about, stridor, hoarseness, respiratory distress, they necessitate early and definitive airway management. Get that breathing tube in quickly. And because the tissues can be swollen and incredibly fragile, intubation should ideally be done by the most experienced person available, often using specialized equipment like a fiber optic scope past the nose, nasopharyngoscopy, to see better and be gentler. A surgical airway, like a cricothyrotomy or tracheostomy, is a second choice if intubation isn't possible. Now, corticosteroids are generally controversial for preventing esophageal strictures, but a dose may be considered specifically for airway edema, the swelling in the airway itself, like dexamethasone, to help breathing. But that's just for the airway, not the esophagus generally. Then, hemodynamic support. Patients can go into hypovolemic shock from fluid shifting out of blood vessels, from vomiting, or from actual bleeding. So getting large bore IV access quickly and starting fluid resuscitation is vital. And of course, healthcare workers need to wear appropriate personal protective equipment, PPE, to avoid getting injured themselves by the substance.
Okay, airway and fluids first. What about trying to get the substance out or neutralize it, like making someone vomit?
Ah, yes. Gastrointestinal decontamination. This is where things get really important, mostly because of what not to do. Several common interventions are generally not indicated and can be actively hazardous. Induced emesis, making the patient vomit, is absolutely contraindicated, full stop. It re-exposes the esophagus and mouth to the caustic agent, doubling the injury, and significantly increases the risk of aspiration and perforation. Never do it. Activated charcoal is also contraindicated in almost all cases. Why? It simply doesn't bind well to caustics, acids, or alkalis. It's useless for that. Plus, it makes the inside of the stomach black and gunky, which completely obscures the view if they need an EGD. The only potential exception for activated charcoal is very specific. Ingestions of zinc chloride, ZnCl2, or mercuric chloride, HgCl2. And even then, it's not to treat the local burn, but to try and prevent the severe systemic toxicity these heavy metals can cause by absorbing them in the gut. That's a rare, specific indication.
What about washing it out, giving water or milk?
Dilution with water or milk. Its utility is really very limited, maybe even negligible in most cases seen in the ER. The only time it might offer some small benefit is immediately, like within the first 5 minutes, right at home after an accidental splash or sip. And only small volumes, given voluntarily. Never force fluids. Trying to wash it out in the hospital setting is generally not helpful and could induce vomiting, which we want to avoid. And trying to neutralize the substance, giving a weak acid for an alkali ingestion or vice versa, is also contraindicated. Big no-no. These reactions release heat, exothermic, potentially causing thermal burns on top of the chemical burns. They can also release gas, increasing pressure inside the stomach or esophagus, raising the perforation risk. Don't attempt neutralization.
Okay, so basically don't try to get it out or neutralize it in the hospital. Secure the airway, give fluids. What about medications? Steroids, antibiotics?
Pharmacological interventions? Yeah, this area is quite controversial, especially regarding steroids. Corticosteroids, highly debated for decades. The thinking was they might reduce inflammation and scarring, thus preventing strictures. However, multiple studies have shown no benefit and possibly harm, like masking infection or increasing perforation risk in grade 1, grade 3, or the very severe grade 3 injuries. However, there is some evidence, particularly from one often cited prospective study, suggesting that high-dose steroids like methylprednisolone started early might reduce stricture formation specifically in patients with grade I circumferential esophageal burns. Remember, this group has a very high risk of stricture, up to 75%, but a relatively lower risk of early perforation compared to grade 3. So that specific subgroup is where steroids might still be considered by some experts, but it remains controversial. They are definitely not for grade 1 or 3.
Okay, so steroids maybe, sometimes, for that specific grade I group. What else?
Antibiotics. These are not used prophylactically, meaning just to prevent infection. There's no evidence that helps. They're only used if there's evidence of actual infection or a confirmed perforation. PPIs, proton pump inhibitors, like omeprazole or H2 antagonists, these reduce stomach acid. While the caustic injury isn't caused by acid reflux, keeping the stomach acid down is generally considered reasonable as adjunctive therapy to promote healing in an already injured area. There are other things sometimes mentioned, like sucralfate, a coating agent, or mitomycin C, an anti-scarring agent applied topically during endoscopy, but their roles are less established, and mitomycin C has theoretical long-term cancer concerns.
What about surgery? When is that needed?
Surgical intervention becomes absolutely imperative for severe injuries. It's often life-saving. The clear indications for emergency surgery include confirmed or highly suspected GI perforation, like seeing free air on a CT scan, clinical signs of peritonitis or a severely rigid abdomen, persistent shock or hypotension despite fluid resuscitation, that's a very grave sign. Also, finding extensive necrosis, particularly grade 3 burns covering a large area seen on EGD or sometimes suggested by CT findings, or systemic signs suggesting overwhelming injury like rapidly worsening acidosis or coagulation problems, elevated PT-PTT. The goal of surgery is to remove all the dead necrotic tissue, esophagectomy, gastrectomy. Delaying necessary surgery in these situations dramatically increases mortality. Early, aggressive surgical intervention saves lives, and nutritional support is critical throughout recovery. Patients often can't eat for a long time, so they'll need nutrition through IVs, TPN, or feeding tubes placed surgically, gastrostomy, or jejunostomy.
It really sounds like even after that immediate danger passes, the journey is far, far from over.
Indeed. The long-term management and follow-up are absolutely critical and often lifelong. Stricture formation. As we discussed, this is the most common and often the most disabling long-term complication. It can make eating incredibly difficult or impossible. Treatment usually starts with endoscopic dilation. Using balloons or dilators passed through an endoscope to stretch the narrowed area. This often requires multiple sessions over weeks or months. Sometimes esophageal stents are placed temporarily to hold the esophagus open, though their effectiveness is debated and they have complications. For strictures that don't respond to dilation, refractory cases, major surgical reconstruction or bypass surgery might be the only option.
And you mentioned cancer risk earlier.
Yes. This is the other major and perhaps most sobering long-term concern: esophageal carcinoma. Patients who survive a significant caustic esophageal burn, particularly those with initial grade I or grade 3 injuries, have a massively increased risk, estimated at 1,000-fold or even higher compared to the general population, of developing esophageal squamous cell carcinoma later in life. And this risk emerges often decades after the initial injury. The latency period can be 40, even 50 years. Because of this profound risk, lifelong endoscopic surveillance, meaning regular EGDs, perhaps yearly or every few years, starting maybe 15, 20 years after the injury, is generally recommended to screen for early cancer development when it might still be treatable.
1,000-fold increase. That's staggering.
It really is. And there are other potential long-term complications too. Chronic GI bleeding, abnormal connections forming between the esophagus and trachea, tracheoesophageal fistulas, lung problems from aspiration, or issues with the stomach not emptying properly, gastric outlet obstruction. We should also briefly mention special cases like button batteries. If lodged in the esophagus, they need urgent endoscopic removal. And ocular exposures, eye splashes, immediate copious irrigation with water or saline is the first step, followed by urgent ophthalmologist assessment. Managing all this complexity really underscores the need for a multidisciplinary team approach. You need close collaboration between emergency medicine, surgery, gastroenterology, GI, radiology, critical care nurses, nutritionists, and very importantly, mental health practitioners, especially when dealing with intentional ingestions, to support the patient through a very long and difficult recovery.
Wow. Okay. We have certainly taken a deep dive into caustic ingestions today. What a journey it's been, from just defining these chemicals to understanding the intricate dance of the body's response and all the critical interventions needed. It's definitely given me a whole new appreciation for, well, the common products maybe sitting in my own home right now.
Yeah, and just to maybe reiterate some key takeaways, caustic agents chemically destroy tissue acids, causing coagulation, necrosis, often limited initially. Alkalis causing liquefaction, necrosis, often penetrating deeper. The injury progresses through phases, including that really critical period of low tensile strength between days 5 and 14, where delayed perforation is a major risk. Remember the unreliability of initial signs and symptoms. Don't be fooled by a patient looking well initially. Airway assessment is paramount. EGD is the gold standard for diagnosis and grading, ideally performed in that 12 to 24-hour window. And critically, remember those contraindicated interventions. No induced emesis, no charcoal except for ZnCl2, HgCl2, systemic toxicity, no neutralization, limited role for dilution. Emergency surgery is life-saving in severe cases with perforation or extensive necrosis. And long-term, it's about managing strictures and that crucial lifelong surveillance for the 1,000-fold increased risk of esophageal cancer after significant burns.
This conversation really hammers home the hidden dangers that might be lurking in our everyday environments, doesn't it? And the incredible complexity involved in treating these medical emergencies. So what stands out most to you, perhaps, from our discussion today? Maybe the fact that a simple laundry pod could actually be way more dangerous than anyone ever imagined, or the critical timing needed for that diagnostic EGD.
That's a good reflection. I think for me, it's the sheer ubiquity combined with the potential severity. So maybe a final thought for everyone listening. Given what we've discussed about how widespread these agents are and the different ways they can cause harm, just take a moment to think about your own environment. Are there maybe hidden dangers you've unknowingly overlooked? Whether it's under the sink at home or maybe in your workplace, how might knowing this change your approach to product safety, how you store things, or even just what you keep an eye out for, especially around children?
That's definitely food for thought. Until next time, keep digging, keep learning, and stay well informed.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.